Hello, I'm Virginie Meau-Petit, consultant neonatologist, and thank you for joining today this introduction session on lung ultrasound in the neonate. I have no conflicts of interest to declare. From this tutorial, you will learn about the current evidence in adult pediatrics and neonates for the use of lung ultrasound, the equipment required, the settings you will have to check before starting your examination, the practicalities of the ultrasound examination in the neonate, and lastly, the description of the normal lung on lung ultrasound. The performance of lung ultrasound has been shown to be excellent from adult studies, which compared lung ultrasound and CT scan as gold standard for main lung pathologies, which are pleural effusion, consolidation, interstitial syndrome, and pneumothorax. Description of all lung ultrasound patterns have been fully described in the book named Lung Ultrasound in the Critically Ill, the Blue Protocol, and written by the inventor on the lung ultrasound, Daniel Lichtenstein. In view of the growing interest and increased number of publications related to lung ultrasound, international evidence-based recommendations have been published in 2012. They involve 28 experts from 8 countries who met 3 times in a year and came back with 65 strong recommendations. They issued recommendations for pneumothorax, interstitial syndrome, lung consolidation, pleural effusions in pediatrics and neonates. As a summary of this exhaustive and long document, they have shown that lung ultrasound is superior to chest X-ray to rule in or rule out the diagnosis and outcome of the following pathologies: pneumothorax, interstitial lung syndrome, and pleural effusion. For consolidation, lung ultrasound has been shown at the time in 2012 to be as performant as chest X-ray, except for mechanically ventilated patients where lung ultrasound is more accurate than chest X-ray to detect and distinguish various types of consolidation. In pediatrics and neonates, more specifically, recent international evidence-based guidelines have been published for point-of-care ultrasound, and this includes lung, heart, abdomen, and catheter. They concluded that POCUS lung ultrasound was helpful to distinguish between RDS and TTN, to detect pneumonia, to help with the management with ERDS, to recognize meconium aspiration syndrome, to detect pneumothorax, to insert chest tube or perform needle aspiration, to guide thoracocentesis, detect pleural effusion, anesthesia-induced atelectasis, and lung edema. So which machine should we use? So any machine and any probe can be used. But we will see on the next slides how to optimize the settings. However, best POCUS machines, well described by Daniel Lichtenstein, should be ergonomically easy and quick to move at the bedside and be switched on quickly. Our choice in our unit was to purchase a small portable laptop machine, but many new machines are now available for POCUS, and I strongly encourage you to try them in your unit, in your practice, and especially if you want to buy more equipment to implement POCUS in your unit. So in terms of probes, the probe most frequently used for lung ultrasound in the neonate is the linear high-frequency probe, which can be linear or microlinear or hockey stick. And I encourage you again to try them all. In lung ultrasound, we explore regions of the lungs which are very superficial, thus requiring a high-frequency probe. Other probes, such as microconvex probes, can be used with a lower frequency, and they may be necessary to explore deeper structures, such as the diaphragm, or an extensive consolidation, or a significant pleural effusion. So the creation of lung ultrasound images involve reflection, diffraction, absorption of lung ultrasound beam. And the highest the difference in acoustic impedance between two tissues, the highest is the reflection and the brightest is the image on the screen. So during lung ultrasound, we can observe that the difference in acoustic impedance between soft tissue here and air here is very high. It's 400 for air and 1.6 millions for muscle, soft tissue, and water. So this high reflection rate between soft tissue and air, which reach 99% of reflection, will create an echogenic line here, which is the pleural line. Here you have the subcutaneous, the soft tissues. Here you have the air, and this high ultrasound reflection will create this bright image of the pleural line. This will also create other echogenic images, such as when the beam encounters the cortical bone. The difference in acoustic impedance between soft tissue and bone, we create 40% reflection of the wave, and the rest is absorbed, creating a posterior shadow. So here we can see the ossified bone of the ribs, creating a high reflection of the waves, creating this image, linear image, which is very bright. And posteriorly to these ribs, we can see a total attenuation, which creates a posterior shadow. As for any POCUS examination, main settings to adjust before your starts are first, the depth, which should be set up at 3 to 4 centimeters. Second, the gain, which is the signal intensity brightness of your image. And this can be adjusted globally or focally on the time gain compensation. Time gain compensation being here. And the focal, which needs to be adjusted on the pleural line. To summarize recommended machine settings for lung ultrasound in the neonate and following recent recommendation published here in 2021, we should use 1 to 2 focus at the level of the pleural line, adjust the depth at 3 to 4 centimeters, and this could be changed according to the different patients and pathologies, optimize time gain compensation to obtain a uniform image, record loops only, not image, for a duration of 3 to 6 seconds, and mainly remove harmonics, as they can decrease visualization of the pleural line and main lung ultrasound artifacts. It is very important to scan both lungs completely, anterior, lateral, and posterior fields from the apex until the thoraco-abdominal junction. So for reporting and labeling, each lung is separated into 3 regions, which is the anterior region here, limited by the sternum and the anterior axillary line. The lateral region is located between the anterior and the posterior axillary line, and posterior regions which extend between the posterior axillary line and the spine. Each region can be divided into superior and inferior, and each area needs to be fully examined. And for each region, we perform a vertical and a horizontal scan. It can be useful for each NICU to choose and agree on acronyms for each view as suggested here. So in our unit, we have adopted RAA, which means right anterior apex, right anterior base, right axillary, right posterior apex, right posterior base, and same for the left lung. Other units have adopted other acronyms. It just needs to be discussed within your unit. And this is important for quicker labeling during scanning and for your reports to localize abnormalities. There is currently no universal labeling on the views. There are conventions for image orientations. For vertical or longitudinal scans, head here should be, and the lung apex should be on the left side on the screen, and the foot and base of the lung should be on the right side of the screen. For the longitudinal or transverse scan, the right side of the patient should be on the left side of the screen, and the left side of the patient on the right side of the screen. Basic anatomical structures are detailed here. From the chest wall, here, this is all the chest wall, the skin, the fascia and the muscle, the upper and the lower rib, here upper and lower rib, in vertical scan, as well as the intercostal muscle, which can be seen here on the drawing and here on the ultrasound image, can all be identified. And below the chest wall, we have the lump parenchyma, which can be assessed from here and below the pleural line. The pleural line is the first step of your lung ultrasound examination. This image is created by the high reflection between the soft tissues and the air present in the lung. It appears as a bright, thin, regular, and sliding line. And the lung sliding reflects the movement of the parietal pleura against the visceral pleura during breathing. An absence of pleura sliding is always pathological. Lung sliding can be demonstrated, visualized on the M mode. The cursor is placed here, as you can see, between two ribs. As the chest wall is static, it appears as horizontal line at the level of the diaphragm. The movement of the lung creates a granular image. At the level of the pleural line, This movement, this sliding between the visceral and the parietal pleura, creates a granular image, which we call the shore. So this image is called the seashore sign. We can also see some additional granular image. I would highlight here and here and here on the shore, which are named the lung pulses, and they reflect the transmission of the heartbeats to the pleura. As the normal lung contains 98% of air, most of the images produced by the lung will be artifacts. So once the pleural line has been clearly identified and described, we have to look for the first artifact, which are airlines. So airlines are physiological reverberation artifact of the pleural line. They are created by the reflection of ultrasound beams between the probe here and the pleural line. They reflect the presence of air. They are static, they are horizontal, and they are separated by an equal distance, which is the distance between the skin and the pleural line. So to explain further, the high difference in acoustic impedance between the soft tissue and the air and the lung results in a high reflection of the beam and the visualization of here, the pleural line, here and here. Some of the waves are transmitted back to the probe, and some are reflected back from the probe to the pleural line. So some of the waves here will come back to the probe and be transmitted to the machine, but some will be reflected back from the probe to the pleural line. And this will create the first A line. So first wave comes from the probe, go to the pleural line, come back. The signal is transmitted to the machine and you create the pleural line. But some of the waves will not be absorbed by the probe, but reflected back to the pleural line and come back again to the probe, creating the first A line. And the process subsequently recurs, creating other lines. So this is here the image of a normal lung. So let's observe now how a normal lung looks like on the ultrasound. So the first step of your examination, I remind you, is to identify the pleural line, upper limb, upper rib, lower rib. You have the head, you have the foot. So this line is very bright, it is thin, and it is regular. And you can see that a small movement of this line. We say that this line is sliding. It means that you can see slightly moving like an ant army marching. And below the pleural line and spaced with the same distance between each other, we can visualize these bright horizontal and static lines, which are the lines. You can also see them on the horizontal scan. So here on this view, because we are between two ribs, you don't see the upper and the lower rib. And finally, you can also observe here that behind each ossified rib, there is a shadow. You cannot see pleural line, you can't see the A lines. It's because all the waves have been absorbed by the bone. So as a summary, the normal lung on the lung ultrasound will be defined as a regular pleural line, lung sliding, and presence of A lines. It is also important always on your examination to visualize the thoraco-abdominal junction, as it has to be part of a full examination. And it will show here. So you see it's the right anterior base. We can see here upper rib, lower rib. We can see the pleural line, A line. And here you can see the liver with thick muscle here, which is the diaphragm. So it's important that your right anterior base image includes the liver on the right and the spleen on the left. It is also important to know the limitation of lung ultrasound. It requires a systematic examination of all lung fields. If you compare with chest X-ray, with one film, you can see both lungs. So you have to be as exhaustive as possible with your lung ultrasound, exploring all lung fields. Remember that the lungs must be in contact with the lung surface because all what you will interpret will be close to the surface. But if we think about the neonatal pathology, almost all of them can be seen, have some feature close to the pleural line and can be examined from the lung surface. And to finish with this limitation, we need to be aware that lung ultrasound cannot really be diagnosed over distension. So as a conclusion, after this tutorial, you can choose the right probe, adjust settings on your machine, perform lung ultrasound in a neonate, and recognize a normal lung. Thank you very much.